I think so. Just Narendra, are you online? Sridevi, are you online?
Yeah, no, yes, Dr. Harish, ready. Ready,
Yes,
sir.
Yeah. Then you can start the presentation.
Sure, sir.
Yeah.
Good morning. I'm presenting a 42-year-old female who works in Oman as a banker. She came with the complaints of lump in the right breast since 8 months. History of presenting illness. She was apparently normal 8 months back when she noticed a lump in her right breast while taking a shower. She gives history that it was initially small in size and then gradually progressed over the period of 8 months to its present size. On further inquiring, she also mentions that the skin over the lump has thickened and there is thickening and retraction of the nipple. There is no history of pain associated with the lump. There is no history of fever or trauma to the breast. There is no history of any nipple discharge. There is no history of any other swelling in the armpit or the opposite breast. There is no history of cough, chest pain, breathlessness, or hemoptysis. No history of weight loss or decreased appetite. No history of low back pain or bony pains. No history of jaundice, abdominal pain, or abdominal distension. No history of headache, vomiting, or seizures. For the above complaints, she was evaluated outside with imaging and a needle test, following which she was referred here. She does not give any history of comorbidities, and there were no history of any past surgeries or biopsies in the past. There is no history of breast cancer in first and second degree relatives, no history of breast, ovarian, and pancreatic malignancies in the family. Her menstrual history, she attained menarche at the age of 14 years. Her cycles were regular, 4 days of duration, and once in every 28 to 30 days. She is an unmarried lady, nulliparous, and there is no history of any OCP usage. Personal history, she consumes a mixed diet, has a normal appetite and regular bowel and bladder habits. Sleep is adequate and there is no substance abuse. To summarize, she is an unmarried nulliparous 42-year lady who presented to us with complaints of lump in the right breast since 8 months, which has gradually increased in size and is associated with skin changes with no significant family history or comorbidities.
So, what do you think? What are you thinking on diagnosis
Sir,
at this level?
Given that she is a perimenopausal lady, a 42-year-old who is nulliparous, I would like to consider my first diagnosis to be a case of malignancy, sir. There are other causes which could also have skin involvement, such as granulomatous mastitis or even tuberculosis of the breast, and but these usually present with pain. And in this patient, there is no history of any pain, sir.
Now, why do you think it is a malignant one thing? And what do you mean by perimenopausal age? What is the meaning of the perimenopause? What is that? How do you conclude that she is perimenopausal?
Sir, in India, the age of menopause is around 46 years, plus or minus 5 years. And
she is not Indian. She is Oman. She is from Oman or she is Indian?
She is from Oman, sir. In Oman, I'm not sure of Oman, sir, but Western world, the age of menopause is 51 years, plus or minus 5 years, sir.
No, Dr. Aaron, if menopause is 46, you call 42 perimenopausal, is it? I don't know. I don't think that term perimenopausal exists now. It's either premenopausal or postmenopausal. And perimenopausal in our times was, I think, 6 months to 1 year, not more than that.
Okay, ma'am.
I don't know. I don't know what Dr. Harish and Narendra have to say about that.
Yeah. I mean, yes, sir, please.
She's, for all purposes, a premenopausal lady.
Premenopausal, ma'am. Okay.
Yeah.
No, whether this status, peri or peri-post, I mean, peri particularly, which you are talking about, does it have any treatment relevance?
Sir, in premenopausal age group, the incidence of breast cancer, especially early breast cancers, are aggressive, sir. In postmenopausal, they are more of associated with estrogen receptor positive rates, sir.
You are more worried about perimenopausal status, no? So, what is the relation? Why are you interested about this word, particularly perimenopause?
This has more bearing on treatment or on the diagnosis?
Sir, it has got more bearing on the diagnosis, sir, and even on the treatment, sir. Most of the postmenopausal ladies have low grade and estrogen positive status, sir, and they have significant luminal A variety and have a good prognosis, sir.
You're talking
what is
same
it?
scenario, Arun?
In this case scenario, ma'am, she is a 42-year-old lady
Okay.
who is premenopausal. She is nulliparous, and given that she has noticed that there are skin changes and there is some amount of thickening over the nipple, I would still consider my first diagnosis to be a malignancy, ma'am.
Okay, fair enough. Now you said that you thought of tuberculosis or you ruled out tuberculosis. How often do you see tuberculous mastitis in your practice there?
Ma'am, I have not seen one. It's a very rare condition. It is usually associated with active pulmonary tuberculosis as well, ma'am.
Not necessary, but it's quite a rare condition. To make a
Yes, ma'am.
diagnosis, very rare. Okay. So in your history, what are the risk factors she has? You've already elucidated it, I think, for malignancy.
She is a nulliparous lady, ma'am.
What is the risk of nulliparity over a multiparous lady?
The relative risk is 2, ma'am, up to 2 times the risk, ma'am.
Okay. What are the other risk
Especially
factors she has?
in a lady, early pregnancy is a protective factor, especially when she has her first full-term pregnancy before the age of 20 years. As the age increases, if her first full-term pregnancy is beyond 35 years, then it becomes a risk factor, ma'am.
Okay. Now, a lady who has a childbirth at 37 and a nulliparous lady, who has a higher risk?
A nulliparous lady will have a higher risk, ma'am.
Why is it so?
There is unopposed action of estrogen, as there is no break from her menstrual cycles.
Okay. You said that she does not use OCPs. Now, why would an unmarried lady use OCPs, Dr. Haran?
She actually doesn't give any history of sexual activity, ma'am. But on inquiring, she mentioned that she has never used any OCPs.
Okay, that's okay. What are the other uses of OCP besides contraception? You are aware?
OCPs are used in for regularization of the menstrual cycles, ma'am. They
Okay. About the family history, you said she has no family history. What is the
No
significant
family
family history? How would you
Ma'am,
define somebody with a very significant family history?
Ma'am, a significant family history is presence of a genetic predisposition of breast cancer with a mutation in the family, or having first degree relative of breast cancer under the age of 50 years, or first degree relative with the presence of an ovarian cancer, or first degree male breast cancer, or prostatic or pancreatic cancers, ma'am.
So this is the BRCA, hereditary breast and ovarian.
Yes,
Any
ma'am.
other syndromes where you have breast cancer as one of the components?
Ma'am, the other associated genetic syndromes where breast cancer is a part of it is Lee-Fromeni syndromes, Cowden syndrome, Peutz-Jeghers syndrome, ma'am. And even in ataxia telangiectasia, you can see breast cancer associated, ma'am.
She has no history, no family history.
No history, ma'am. Even diffuse hereditary gastric cancers, they have incidence of lobular carcinomas, ma'am.
Lobular cancer.
Yes, ma'am.
Okay. So, can he go to the examination, Dr. Harish and Narendra?
Yeah.
Proceed, Dr.
Yes, ma'am.
Yeah.
General physical examination, she was conscious, cooperative, well oriented to time, place, and person. She is moderately built and well nourished. Her height is 156 centimeters, weight of 81.6 kgs, body mass index of 33.5 kg per meter square, ECOG 1. Pulse is of 80 beats per minute, blood pressure 130 by 80 mm of mercury in right arm supine position, afebrile. She does not have any pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. After adequate consent and adequately exposing the patient in the presence of a female chaperone, she was examined by arms by the side, arms raised above the head, hands placed on the hips and in bending forward position. On arms by the side, there is fullness noted in the right breast, upper outer quadrant and lower quadrant. And it is the breast appears to be higher up as compared to the opposite side with retraction of the nipple areolar complex. There is skin puckering present over the upper outer quadrant. Pudgy orange is present. No ulceration, scars, sinuses, or dilated veins. Nipple retraction is present. Nipple areolar complex is placed at a higher level as compared to the left breast, and there is no nipple discharge. On arms raised above the head, the nipple areolar complex appears to be pulled up. Skin puckering is noted in the upper outer quadrant. Both the breasts fall freely forwards. There is no edema of the arms, no fullness noted in the axilla or supraclavicular region. The left breast axilla and supraclavicular fossa appear normal. She was examined on palpation in semi-recumbent and sitting position with arms by the side and arms over the hips. All the inspectory findings were confirmed. Left breast and axilla were normal. The breast size was 38D, stosis of grade 3. There is no local rise in temperature, no tenderness. A solitary 7 into 5 centimeter lump is noted over the right breast in the upper outer quadrant from 8 o'clock position to around 1 o'clock position. The surface over the swelling is smooth, it is irregular margin, firm to hard in consistency, and it moves with breast tissue. Tethering is present at around 11 o'clock position. Overlying skin is not pinchable with pudgy orange appearance, and it is not fixed to any underlying structure. Nipple retraction is present, which is partial with no nipple discharge. Right axilla does not have any, I could not appreciate any palpable lymph nodes. There are no supraclavicular nodes on both sides. Coming to systemic examination, respiratory system bilateral air entry is equal, no added sounds. Per abdomen is soft, non-tender, no palpable mass. She was not compliant for a pelvic examination. Ideally, I would have liked to have a pelvic examination done. Central nervous system, no focal neurological deficits. Musculoskeletal system was normal and there was no bony tenderness. Cardiovascular system, S1, S2 was heard, no murmurs. To summarize, I have a 42-year-old nulliparous unmarried premenopausal lady who presented with a painless progressive lump since 8 months in the right breast. On examination, it was a solitary 7 into 5 centimeter hard non-tender lump with pudgy orange appearance over the skin. It is not fixed to any underlying structure or chest wall with no palpable lymph nodes in the axilla. I would like to give a diagnosis of carcinoma right breast. My stage would be clinically T4B N0M0.
Any differential diagnosis?
Ma'am, it's a solitary lump which is involving the skin with pudgy orange. My first diagnosis would be carcinoma breast, ma'am.
I asked you if you have a differential diagnosis, that's all. Or you are just going to say malignancy only is what I'm asking you.
I would like to keep it as malignancy only, ma'am.
Why not phyllodes tumor?
Sir, phylloids also appears in the same age group. It is rapidly progressive and the skin over the surface is ideally not involved. There can be ulcerations, but it is usually stretched, and the skin ulceration is usually because of pressure necrosis. And there are always some associations of bosulated surface and dilated veins which are seen over the breast.
You said the surface of this tumor is smooth, no?
Yes, ma'am.
That's the usual finding for a malignancy to have a smooth surface. Use the word smooth. That terminology is generally not used for a malignant I don't know.
Okay, ma'am.
Fine.
It felt
There
smooth.
are no
ma'am.
axillary nodes, right? So it may
There
not.
There were no axillary nodes in this patient, ma'am. I couldn't appreciate any.
That's why I'm
And,
asking, why not a Phillips tumor when nodes are negative with N0 in the axilla? And you told it's a smooth swelling, and if you see the picture where the front this thing is, why did you consider Phillips as one of the options?
Sir, involvement of the skin with the PUD orange and also involvement of the nipple areolar complex gives a differential against phylloid tumor, ma'am.
Okay.
Right, proceed. And you said the patient was not willing for a pelvic exam. If she was willing, what would you have looked for?
Ma'am, if she was willing, I would have looked for any adnexal masses or any deposits in the pouch of Douglas, ma'am. Any other deposits.
Fine. Now you said the underlying structures are not involved. Which are the underlying structures you tested and how?
Ma'am, I look for pectoralis major. I look for serratus anterior. Pectoralis major, I made the patient keep her, with appropriate consent, keep her arms on the hips, and in a relaxed position, I palpated the lump and moved it in two directions, one along the fibers of the pectoralis major and one against it. And I asked her to contract, I asked her to press against her hips, check for the axillary fold if the pectoralis major is contracted, and then moved against the fibers and in line of the fibers. If it is fixed to the pectoralis major muscle, then it will not move, has got restricted mobility, ma'am. And
along or across?
It will have restricted mobility across, ma'am.
Across.
Yes, ma'am.
You mentioned also there was PDO and you also mentioned skin tethering. What is the difference between the two?
Ma'am, in PUDO, there is actual skin involvement, and it is because of dermal lymphatic infiltration by tumor emboli. Whereas in tethering, the skin is actually free and the lump can be moved. So, in her case, ma'am, the lump can actually be.
You're going fast. The skin can be moved.
The skin will be.
What is the meaning of tethered then?
Ma'am, the breast tissue is involved, and the Cooper's ligaments surrounding the breast tissues are involved in tethering. The skin is actually pinchable, but at one point, one position, the PUD orange is there, and the other position, there is that dimple which is seen, and there is that tethering is also there, ma'am.
So, as an oncologist, you're not bothered about skin tethering. You're concerned only about PDO, is it? Do I read it like that?
PUD orange will actually stage the disease. The tethering will actually not stage it, ma'am. PUD orange will be T4B. Skin changes and nipple retraction will not alter the T stage, ma'am.
Why? You're correct. You're correct. Why?
Because skin changes as such can be.
You already partly answered it. Tell me why. Why tethering or nipple retraction don't alter the staging? Tethering is due to what?
Involvement of the Cooper's ligament, sir.
What alters the
underlying
staging?
breast tissue.
What alters the staging? Involvement of
skin.
Skin. Is Cooper ligament skin?
No, sir.
That is why it doesn't alter.
Okay.
Understand? Nipple retraction is due to what?
Nipple retraction is due to involvement of the lactiferous ducts, sir.
Is lactiferous duct skin?
No, sir.
That is why it doesn't alter the stage. Understand?
Yes, sir.
Okay. Continue.
She was already investigated outside, so she came to us with an ultrasound of the breast.
Just a minute. If the PUD orange was different, was not there, what would be your T stages?
Sir, if the PUD orange would not be there, then my T stage would be T3N0M0, sir.
How many such large lumps have you seen in your experience in the last few years?
I have seen many, sir. But
many. How many of them are N0?
Most of them are present with an axillary node. If it's a 7 into 5 centimeter lump, there is always an axillary node which is palpable. They will always be in stage 1 or N1 or N2. This lady, I couldn't appreciate any nodes in the axilla.
Okay. Okay, continue.
I would like to further investigate and confirm my diagnosis. This lady had actually got all her investigations done outside, including the needle biopsy.
Okay.
She had an ultrasound of the breast which showed a large hypoechoic mass with irregular margins involving the whole of the breast and large bulky lesion extending from 9 to 12 o'clock. It was around 4.5 into 3.5 centimeters. There was another lesion which was seen anterior to the mass. There was another lesion which was there in the lower outer quadrant, which showed measuring 3.8 into 2.3 centimeters, and there was no suspicious axillary nodes. She also had a mammogram which was done.
Could you interpret the mammogram?
Yes, ma'am. Ma'am, this is ACR grade B, ma'am. It is not adequately exposed. The pectoralis major muscle in the medial aspect is not seen, and the inframammary folds were also not visible in the whole picture. This is ACR grade B. There is a architectural distortion and mass like heterogeneous density in the upper outer region with speculations which are seen. There is associated skin thickening as well as there is.
You have a marker. Can you just show me where the mass with speculations are?
Ma'am, this is the mass, ma'am.
That
And
is
there
the
is
mass.
heterogeneous.
Where are the speculations, Dr. Aaron?
Ma'am, these are the speculations which are seen, ma'am.
I'm not sure. You look at the other breast also, you can see parenchyma very similar to that. I definitely can't make out. There is some distortion. AD is definitely there, but
Okay, ma'am.
Okay, it's okay. It's okay. I could be wrong also. Okay, continue.
Okay, ma'am. And there is associated skin thickening which is seen, and the nipple is retracted on the craniocaudal view, ma'am. In the medial lateral oblique view, there is a mass which is seen, which is hyper intense, and there is associated retraction of the nipple and skin thickening. The mammogram is not adequately exposed because the pectoralis major muscle is not well defined on the right side.
No, it is seen reasonably well.
Okay, ma'am.
Oh, no. Please, what your arrows on the pec major, right?
Yes, ma'am. But yeah.
No, contrast it to the other side. Other side.
The other side, it is better exposed, ma'am. Even the inframammary fold also is open. But on the right side, there's a little less amount of pectoralis major which is seen.
Okay. And in that visible pectoralis major, can you see some tethering towards the mass? I don't know if that's significant. Anyway, can you see the second lesion on the mammogram?
Yes, ma'am. There's a small lesion here.
Yeah. Okay. Fine. So this is both the views you've showed us.
Yes, ma'am.
Fine. Okay.
So our mammogram reported to have a 38 into 23 mm high density architectural distortion noted in the upper outer quadrant of right breast with multiple speculation causing retraction of the skin and nipple. And there is another 28 into 17 mm architectural distortion noted in the lower outer quadrant. There were small intramammary nodes which were seen, ma'am.
Suppose I say mammogram is not required. Why do you do a mammogram at all in an existing lump in this case? There's a large lump, isn't it?
Yes, sir.
Why do you do a mammogram at all? I say I don't want it.
Sir, mammogram can be done for a couple of reasons, sir. One, we would like to some of the lumps can be characterized based on the mammogram. Triple negative breast cancer appears more rounded. The second thing is in this case, since it's an advanced, locally advanced breast cancer, she will be planned for a neoadjuvant chemotherapy. So on follow-up to assess response to the neoadjuvant chemotherapy, we will require a mammogram. and we would like to see the status of the contralateral breast as well. That is why this mammogram was done, sir.
Contralateral breast, all right. Ipsilateral, I'm asking. I don't want a mammogram. That is my stand. Okay.
That is
Now
correct,
you tell
sir.
me why I'm right or wrong.
Sir, the only reason why I can think of an ipsilateral mammogram is to check for response assessment in this locally advanced breast cancer.
This is the best method for response assessment. Now, since you're sticking on to it, is mammogram the best method? What we have now?
Ma'am, MRI is the best method which we have for response assessment. But after neoadjuvant chemotherapy, every 2 cycles of neoadjuvant chemotherapy, we would like to do a clinical examination. And if she completes her neoadjuvant chemotherapy, then we would ideally do a clinical examination and a mammogram.
Okay, that's what you do in your center.
Yes, ma'am.
Mammograms for locally advanced and assess with mammogram. Oh.
No, ma'am. This patient had already come with a mammogram, ma'am. We didn't get it done here.
Okay. Fine.
Okay.
Proceed.
Proceed.
So, what BIRADS would you assign her? BIRADS?
Sir, ma'am, this will be BIRADS 5, ma'am.
What is 4A, B, and C?
Ma'am, 4A, BIRADS 4 is suspicious of a malignant lesion, ma'am. It is divided into 4A, B, and C. 4A is mild from 2 to 10%, ma'am, and 4B is moderate suspicious, which is from 10 to 50, and 4C is from 50 to 95% suspicious, ma'am. All 3 of them will require a core needle biopsy for confirmation.
Okay, proceed.
Now, what is special about this? I mean, what have you additional information you got in this? You clinically knew it was malignancy, correct?
Yes, sir. Yes, sir.
What additional information have you got in this?
The additional information was that it is not a solitary lesion which was seen. There were 2 lesions which were there.
2 lesions. Okay. Okay.
Yes, sir.
Okay. Continue. Continue.
She also came to us with a core biopsy of the lung, and it showed invasive ductal carcinoma grade 2, ER positive, PR positive, HER2 new negative, and Ka67 of 10%.
What is the molecular classification?
Sorry, sir. She is luminal A. Sir.
What is, how do you, pardon?
She is luminal A, sir.
Okay. What is the cutoff? How do you differentiate between luminal A and luminal B?
Sir, luminal A and luminal B is differentiated based on estrogen and progesterone receptor status. There is high positivity of estrogen and progesterone receptor status in luminal A, and the Ki67, which is a proliferative index, is the cutoff for us here is 14%, and here it is 10%, and in luminal B, the ERPR positive will be low, and Ka67 proliferative index will be higher. And luminal B can also be associated with HER2 new positive status.
What is the scoring system for ER and PR called, and tell me how it's done?
Ma'am, ERPR scoring system is done by Aldred scoring. It is based on the percentage and intensity of staining of the membranes.
Proportion and percentage.
Proportion and percentage. The proportional staining is graded from 0 to 5, and intensity is from 0 to 3. So total cumulative score of 8. Anything more than 3 and maximum score of 8 is considered to be ER positive and PR positive.
Well, you said high score is the luminal A and the low score is luminal B. So any cutoffs are there for high and low in amongst the positivity? Positive score, sorry.
I'm not sure, ma'am, but luminal B maybe ER less than 3 and
3 is negative. Negative. You said less than 3 is negative.
I'm not sure, ma'am.
Okay, I don't know. How is the grade assigned, Dr. Aaron? The grade 2 based on what?
Ma'am, grade is assigned based on Ellison's Elston's a modification of Richardson-Bloom's scoring, ma'am. It is based on
Yeah, go ahead.
it is based on tubules, nuclear atypia, and mitosis, ma'am.
Okay. So for grade 2, what is the
Ma'am, it will be around 4 to 6, ma'am. The score.
And what is grade 1 then?
I'm not sure, ma'am, but
Fine. Go on, please go read. What you said is wrong. Okay.
Yes, ma'am.
Continue. What else? You've got a core biopsy, and contrary to what you said, this is a luminal A. You said young
Yes,
people
ma'am.
will not have luminal A, and all. You said something.
Yes, ma'am.
That blanket statement is not correct.
Okay, ma'am.
No. Okay. You've seen it now, no?
Yes,
You
ma'am.
said young people don't have luminal A's and all. You said. Continue.
Yes.
What else you want to do now? You got a biopsy. You have a mammogram.
I would like to get a metastatic workup done for her. This lady already presented to us with a PET CT scan, ma'am. So this is a PET CT scan. It showed 2 separate lesions in the upper outer and lower outer quadrant with the involvement of skin thickening, and there were no axillary lymph nodes which were seen. So it was told that it is a multicentric right breast lesion with few subcentimetric non-FTAG right axillary lymph nodes which were seen, ma'am.
No other place of uptake, is it?
No, ma'am. No other place of uptake anywhere.
Supposing she hadn't come with the PET CT, what is your preferred metastatic workup?
Ma'am, my preferred metastatic workup in our institution is contrast NSCT of the chest, abdomen, and pelvis, ma'am. The bone scan.
Bone scan. So you don't do PET CT at all, is it, for a breast cancer? When is it done then in your setting? When do you all ask for a PET CT in your practice?
In case of if the patient presents with symptoms of metastasis or it's a very advanced breast lesion, then we do a PET CT, ma'am. But most of the times we would prefer to stick with the contrast and CT of the chest, thorax, and abdomen and pelvis with a bone scan. I would like to counsel the patient.
So finally, what is her stage now after the?
Ma'am, she's T4B N0M0, ma'am, stage 3, ma'am. Locally advanced breast cancer.
Okay.
Is there anything you put in TNM that with these investigations on the
Clinical, sir. C
is okay. There is something in the investigations, something differential or not?
Sir, there are 2 lesions actually. So I will put another M, sir, in brackets.
Okay.
I would like to discuss this case in a multidisciplinary team meeting, ma'am, and then I would plan for a neoadjuvant chemotherapy for this lady. I would counsel the lady regarding the benefits and risk associated with the chemotherapy, and would like to assess the response of neoadjuvant chemotherapy, and then would plan for a modified radical mastectomy.
She is a luminal A lady, no? Luminal A. So what
Yes,
do you
sir.
think? How much with the response to chemotherapy?
Sir, the response to chemotherapy will be very minimal, sir. But she's a T4B lesion lady. We will not achieve a pathological complete response because the pathological complete response rate is only about 8 to 10% in luminal A.
Operate on her. Then don't give neoadjuvant. Do surgery for her. Is there
Are there any other options?
surgery?
It's a large breast lump, ma'am, with skin involvement. Ideally, I would like to consider to go ahead with neoadjuvant chemotherapy, probably downsize it a little bit. The benefit of that is I will know the response to chemotherapy and
What about neoadjuvant hormonal therapy?
sir, neoadjuvant hormonal therapy is indicated in a very selective subset of patients. They are elderly age group, not so advanced, and it takes a long time to get a response from them. It takes ideally around 4 to 6 months to have a response with neoadjuvant hormonal therapy.
Now I would like to operate this case upfront. What are your objections?
Sir, if it is operable, there is no objection to it, sir.
This is operable. According to me, this is operable. According to me, this is operable. As long as I get a primary skin closure, I will do it. What is wrong in this? What is right in this?
Sir, since she is, I wouldn't say low risk, sir, but if the skin margins are can be approximated, then operating her is one of the options which can be considered, and I would like to discuss this with the patient. There is nothing wrong with it, sir, because she is a luminal A variety of breast cancer.
She has studies are, what is it significant?
Purely evidence, there is dermal lymphatic emboli which is seen. So there is chances that she will have systemic micrometastatic disease also. So neoadjuvant chemotherapy will actually
Not only systemic. If you close skin nodule will appear in the other area.
okay, sir.
Everything is infiltrated there, no?
Yes, sir.
So what chemo you will give?
Sir, for this lady, I would like to give dose dense AC with paclitaxel 2 weekly.
What is the advantage of dose dense?
Ma'am, dose dense is ideally given for high risk and aggressive tumors. It is based that there is a proportion of cells which have a regrowth in between the chemotherapy cycles, and dose dense is used to address this.
Don't you think A67 of 10% and luminal A?
Exactly. Then why dose dense? Aggressive is not an aggressive subtype, no? It's the least aggressive.
Yeah, benefit is less. Yeah, benefit is less. Subsidy will be more.
Yes,
so why can't you give usual AC only?
We can give usual AC only, sir, but our institution we follow dose dense AC with 2 weekly paclitaxel, sir, 4 cycles each.
No, correct. That is, but you have to individualize the treatment to the given patient. No, you cannot blanket give. Now it's coming personalized medicine.
Yes,
So
sir.
for a ERPR positive and a K67 less, you don't see any. Do you see any response? That is the question. Yeah. Okay. Whatever.
The response will be very minimal, sir, in this patient.
Now, as this patient asks you for a conservation after neoadjuvant, what will you do?
Sir, she will not be a candidate for breast conservative surgery, sir, because she is T4B.
Will you tell it upfront or will you tell it later?
No, sir, I will tell it upfront, sir.
Doctor, then why did you keep insisting that you will do a mammogram for assessment of response?
Yes.
You kept on saying PDO, skin tethering, PDO, and then you kept on saying that mammogram I will do to assess response. If you had ruled out a conservation by your clinical examination, exactly like what Dr. Harish said, you needn't have even done the mammogram.
Yes, ma'am. In this case, ma'am, this lady had already got a mammogram done.
That's okay. That we understand. So she's not a candidate for breast conservation.
No, ma'am.
So anybody with skin involvement is not a candidate for breast conservation, is it? Or this lady because she also has a multicentric tumor?
Ma'am, ideally, anyone with the T4B lesion is not a candidate for breast conservative surgery. Locally advanced breast cancers, T3 node positive.
Thank you. Well, I think literature differs with what you say. although I agree with what you say, there is enough literature even from India that says that if you have clinical skin involvement and there is a good response with neoadjuvant chemotherapy, breast conservation can be offered.
Okay, ma'am.
But multicentricity becomes another contraindication in this lady.
Yes, ma'am.
Okay, so you will give AC and Taxol dose 10s and you will see her every 2 cycles, you said.
Yes, ma'am.
Okay. What do you do at the end of the 8th cycle? She has a tumor that is 4 centimeter in size.
I will plan for a modified radical mastectomy, ma'am.
Would you do any imaging at that point? The response is not great from 7 centimeters become 4 centimeter. Would you consider any imaging?
No, ma'am. I will not do any imaging for her.
So you'll plan for a modified radical mastectomy.
Yes, ma'am.
What do you do to the axilla?
Sir, I will clear axillary level 1 and level 2 lymph nodes in this patient. And if there are any enlarged lymph nodes, I will address the axillary level 3 also, sir.
Come again. What did you say? I didn't hear you.
Axillary level 1 and level 2 levels of lymph nodes will be cleared, ma'am. If on this thing, if there are any enlarged lymph nodes, then I will address the axillary level 3 as well.
It was an N0 lymph axilla, right? Clinically,
yes, ma'am.
For you, you see any option to do a sentinel node or something?
Ma'am, ideally, sentinel lymph node biopsy is done in early breast cancers, ma'am, which are node negative. She is a T4B lesion, and I would not consider a sentinel lymph node in this lady, ma'am.
Okay, so you will clear the axilla completely.
Yes, ma'am.
Level 1, 2, and 3 based on the finding.
Yes, ma'am.
What would you expect to see in the pathology report? What are the key things you will look for in the pathology?
In the pathology report, I would like to see for tumor.
What incision would you put for her? This is an upper outer quadrant. Okay.
Ma'am, an elliptical incision would also suffice.
Elliptical towards where? How would you put the ellipse? The transverse or an ellipse?
Transverse, ma'am.
Oblique transverse incision.
Transverse only, ma'am.
What is the margin you attempt to give?
In a modified radical mastectomy, a skin margin of 1 centimeter is adequate, ma'am.
In a BCS, supposing you're doing a BCS, what is the margin you give? Is the margin different for BCS and MRM?
No, ma'am. In BCS, I would like to give a margin of 1 centimeter. The pathologically an ink negative margin would be enough, ma'am.
So for mastectomy and BCS, the margin definitions are the same.
I'm not sure, ma'am.
Okay. So what will you look for in the pathology report?
Ma'am, in pathology report, I would like to see the tumor size, tumor type, the response to neoadjuvant chemotherapy, lymphovascular invasion, and regression, as well as the grade, and would like to see if there are any other in situ ductal carcinoma in situ lesions, and would want a proper staging of the disease, ma'am, along with the number of nodes which are harvested and number of nodes which could be positive, ma'am.
Why are you concerned about in situ component in this lady who already has a T4B and a multicentric? Is it going to change anything? The presence
No,
of
ma'am,
in situ element?
No, ma'am, it will not change anything.
So, which patients will that reading of in situ become important? On a mastectomy specimen? What is the importance of that finding?
Ma'am, in situ component in a mastectomy specimen, it should have a minimum of 2 mm margin, ma'am.
So for margin purposes. I'll just repeat what you said. You want 2 mm margin for the in situ. That's why you're looking at in situ, is it?
No, ma'am. I'm not sure, ma'am.
Okay. So let's assume she has a 4 centimeter tumor. Your margins are free. Lymphovascular invasion is present. The nodes are 1 out of 12 nodes are positive. What will you do? And response is minimal response. What is any scoring is there for assessment after neoadjuvant chemotherapy in pathology?
Ma'am, there are two scorings, ma'am. One is residual cancer burden by
Yes.
American Cancer Society, and there is another scoring called as Miller-Payne's criteria, which gives response to chemotherapy.
Okay. So after this, what do you do for her?
Ma'am, I would like to consider her for adjuvant hormonal therapy and radiation as well, ma'am. Adjuvant radiation.
Adjuvant radiation and hormone. You start the hormone first before radiation, or you will wait for radiation and start the hormone?
I'll finish the radiation first and then I'll start the hormone therapy.
Any concerns are there while starting hormones during radiation?
No, ma'am, not aware of it.
You're not aware. Okay. There are some concerns of using tamoxifen during radiation.
Okay.
So generally, people prefer to wait for radiation, but few people do start earlier. So radiation, what are the fields that you give, and what is the total dose that is given?
Ma'am,
What kind of radiation do you give in your center?
we give an external beam radiation, EBRT.
Everybody gives external beam only, man. What kind of technique do you?
IMRT, ma'am.
IMRT. What do you mean by IMRT?
Image modulated radiation therapy, ma'am.
Why do you do all that fancy things?
Ma'am, with IMRT, we can modulate the dose and organ at risk can be identified and limit the dose to those organs which are at risk of radiation.
Which are in this patient?
Which in this patient would be the lung and the heart, ma'am.
Lung and the heart. What is the total dose given?
Ma'am, 50 gray in 25 fractions, ma'am, over 5 weeks.
What are the fields used?
Ma'am, the chest wall, the drain site, and I would like to cover the supraclavicular fossa as well.
Supraclavicular fossa also. Fine. And what fractionation do you use currently?
Sorry, ma'am.
Fractionation. How many fractions of radiation do you deliver? The 50 gray.
50 gray in 25 fractions, ma'am.
Standard fractionation.
Yes, ma'am. Standard.
So are you aware that there is a hypofractionation that has come up now?
Yes, ma'am. Yes,
what
ma'am.
are the advantages, and why aren't you following it?
Ma'am, in hypofractionation, the duration of treatment will reduce, ma'am. Patients will be more compliant to it. It will be a 40 gray in 15 fractions, ma'am.
Okay. Has it become the standard of care yet?
It has not yet been the standard of care, ma'am, but we do follow it in some of our patients, ma'am.
Okay. Okay, fine. So after she's finished her radiation, what is the hormone therapy you offer her?
Ma'am, in this lady, considering that she's T4B, I would still like to consider aromatase inhibitors, ma'am, followed by ovarian functional suppression for a period of 5 years. I would like to discuss the other option of tamoxifen as well, ma'am. And
why have you put in a premenopausal lady? Why have you chosen aromatase inhibitor?
Ma'am, there are some trials which have shown that aromatase inhibitors fare slightly better than tamoxifen in locally advanced breast cancers.
Which are those trials?
Ma'am, it is text and soft trial, ma'am.
Text and soft, what was the aim of text and soft? To look at ovarian suppression, right? In high risk group.
Yes, ma'am.
You didn't mention that. You mentioned I'll start aromatase inhibitor and then.
With ovarian
So
suppression.
now, for this lady, in all fairness, she's nulliparous, she's 42. You could have offered to even remove her ovaries, right, at the mastectomy time? Was there a case to do that?
Yes, ma'am. In this patient, we can consider doing an oophorectomy as well.
So if given a choice, she asks you to make a decision, you would choose an aromatase inhibitor over tamoxifen.
Yes, ma'am.
Supposing she decides I don't want to, and the other thing is now after 8 cycles of chemotherapy, what do you think will be her menopausal? What will be her status? And would you do any assessment to look at some levels to decide whether you want really an ovarian suppression or you will regardless go ahead with ovarian suppression?
No, ma'am. I would like to assess for serum estradiol and serum follicle stimulating hormones, ma'am.
Yeah. And how long would you give the, supposing she does not opt to have a BSO, how long is ovarian suppression given?
Ovarian suppression, if I'm giving aromatase inhibitors, ma'am, I will give for the full period of 5 years. But I will check for her menopausal status as well, ma'am, with serum FSH and serum estradiol levels.
Given that she is 42 and she has received 8 cycles of chemo, 4-AC and 4-taxane, do you think she would have achieved chemo-induced amenorrhea?
There is a possibility that she would have achieved chemotherapy-induced amenorrhea, ma'am. But this patient is not an Indian patient, ma'am. In India, ideally, the age group of menopause is 46 years. She is from Oman. So, considering her, I'm not sure about Oman, ma'am, but the other Western population, the age group of menopause is around 51 years. So, she still has around 8 years of.
No, but she's received chemotherapy, Dr. Aaron.
Yes, ma'am.
42, she received this chemotherapy, she's most likely going to be having a chemo-induced.
Yes. At any stage, do you consider any surgical oophorectomy in this patient, or when do you consider?
Surgical oophorectomy can always be given a choice in this lady since she is 42 years. I haven't inquired with her whether she plans to marry, but I don't think possibility of children are there, ma'am.
That's what would you discuss BSO with her?
I won't discuss BSO with this lady, ma'am.
The role of neoadjuvant ovarian suppression with hormonal.
No, I'm not sure, sir. I'm not right about it.
Is there anything else?
Yeah, continue. So what follow-up will you do for her? How often would you see her and what are the routine investigations are?
For the first 3 years, I will follow up her every 6 monthly, ma'am. And I would like to do a mammogram.
That's your protocol, every 6 months?
Every 3 to 6 months, ma'am.
So choice is yours or the patient's, whether it's 3 months or 6 months? You said high risk, locally advanced and all, and you'll see after 6 months, is it?
Every 3 months, ma'am. In the first 2 years. And I will get an ultrasound of the abdomen and pelvis and annual mammogram of the opposite breast, ma'am.
Ultrasound abdomen and pelvis, how often? Once a year?
Once a year, ma'am.
What is the idea to look at that abdomen and pelvis? Why don't you do bone scan, do CT abdomen pelvis? Why are you doing only ultrasound? What is the idea?
To look for any adnexal masses, ma'am, or any other.
You're following up her ovaries. So just do an ultrasound pelvis. Why do you want the abdomen? No, what is your idea? If you're following only the adnexa, then just pelvis is enough, no?
Are you looking for metastasis?
Yes, sir. To look at the liver and the adnexa also.
Is that recommended in follow-up of breast cancer in a clinically upfront, early or locally advanced disease to periodically check for appearance of metastasis? What is the recommendation?
I'm not sure, ma'am.
You do it only if the patient has symptoms. You generally
Symptoms.
don't do routine, excepting a contralateral mammogram, as you rightly said.
Okay.
Anything else you would offer this patient? She's 42. Besides, you've done so much. Do you do a genetic testing for her?
She can be considered for a genetic testing also, ma'am. I would like to consider a hereditary breast and ovarian panel for this patient, ma'am.
Yeah. Maybe worthwhile. She's 42, so it could be worthwhile. So, what is the patterns of recurrence for a luminal A?
Pattern
What is her expected survival also at 5 years and 10 years? Luminal A, locally advanced.
Ma'am, luminal A 5-year survival is anywhere up and about 80 to 90%, ma'am.
For a stage 3, huh?
For a stage 3, it comes down to around 70 to 80%, ma'am. But she's luminal A, so 70 to 80%, ma'am.
70 to 80%. And what about the patterns? I mean, the occurrence of recurrence, when do they happen in a luminal A?
Ma'am, in a luminal A, the patterns of recurrence are usually even beyond 5 years, ma'am.
Pardon?
So, even after 5 years, the recurrences can happen, ma'am.
He's asking patterns. Where do they usually come?
Failures.
Failures will happen where?
Is it visceral, bone?
Brain. Visceral, sorry.
They'll
No, ERPR positive tumors typically present with what metastasis?
Why do triple negative breast cancers and HER2 positive patients, where do they fail?
Ma'am, triple negative breast cancers usually fail in the brain and the viscera, ma'am.
Usually, what is the time span? Is it long or is it short?
The recurrences in triple negative breast cancer are usually within 3 years, and the disease-free interval is also less. The lifespan is also less, sir.
What about HER2 new? Where they present with?
HER2 usually tend to have brain metastasis.
Yeah. And what about ERPR positive, luminal A? What is the other thing left? Major organ left?
Bone, sir.
So if this lady undergoes mastectomy, what reconstruction will you consider?
Sir, she can be given options of reconstruction, sir. But in this lady, I would consider for a delayed reconstruction, not an immediate one, sir.
Why?
She has got a T4B disease, sir, which is an advanced breast cancer. Considering that, would like to follow up her for at least 2 to 3 years before considering for a reconstruction, sir.
Is it that the reason or anything else? What are the drawbacks of immediate reconstruction? Somebody in this scenario. What is the flap used?
Sir,
What do you do?
free fed, a tram flap or a free pedicle flap can be used, sir, or diap.
No. What do you mean by free pedicle flap? Free pedicle or free flap, you want to say?
Free flap, sir. Okay. A pedicle flap or a free flap can be used. Deep inferior epigastric perforator flap, sir.
Okay, so what is the problem with them when somebody who receives radiation? Yeah, it's okay anyway. Yes, sir. Already 1 hour over. Madam, any questions?
No, I think we've asked him quite a bit.
Quite a bit, yes, I think so.
Thank you.
Do you
Maybe
have
I
any
think we
questions?
can just give some tips. I think Sridevi, Harish, and Narendra, because all the students are preparing for exam in this month. Maybe what they should not do, what mistakes, how to put it, common mistakes students do in exam. All three of you maybe
Yeah.
do's and don'ts.
Yeah, I think first thing is you have to answer only to the question you are asked. Please understand the question and answer only that. Don't divert away from the question because you may drag yourself to some area which is unknown. If you're asked, will you do a mammogram, you say yes or no. Okay. And then, no, I will also do MRI, is not required. Okay. So, answer to the question, number one. Number two, please understand the question properly. See, for instance, when she asked what are the failures, what are the areas of failure, you should say which organs failure, like bone or viscera, liver, something like that. Recurrences will and failures include local and distal. So please concentrate yourself when they ask failures, will it be a local or a distant failure? Yes, breast especially, whether it's a visceral or a bone, becomes important. So answer to that only. Okay, please understand the question. And second, most important thing is don't be anxious. Examiners are not your enemies or somebody who is going to shoot you down. Just relax and please answer what you commonly do in your place, because certain places have certain protocols and they do it slightly differently. It doesn't matter. But don't think out of the box and tell what you don't usually do. That will put you in a trouble because you will not be able to justify it, because your institute will not do it, nor it will be a recommended one. So don't jump the box and say some crazy thing which you have not seen or done. If you have done a biopsy of the breast, core needle, you say I do a core needle biopsy. Don't say I will do open biopsy because you have not done in your place. Okay, so please stick to what you usually do. Basically, where you falter is you would not have applied your mind when you are a student, when you are in your course. When you are in your course, when you go to the ward rooms or in the OPD on a daily basis, please make up your mind what you want to do for that case mentally. See what your faculty does, and if there is a difference between what you have done or what he or she has done, please check where you are wrong. Either you find out yourself or ask your faculty why they did it differently. Say you want to do a mammogram, your faculty does not do it. Then you should ask why it was not done. If you have mentally made up your mind that you should do it, but they don't do it, just check then and there. What happens is you start applying your mind in the exam first time. That is where you get stuck. Say, for instance, this case was a T4B, right? Now, in this case, suppose skin involvement was not there. Suppose PD orange was not there. Would you have treated it differently? These are the things which you should check regularly in your ward, and then in the exam becomes one of those days. Otherwise, you start thinking differently in the exam, you'll get stuck. Please do it on a regular basis. You won't have much of problem in the exam. And don't be nervous and don't get anxious. Be calm. Answer one or two questions. You don't answer, heaven will not fall down. But the basic concept has to be right. That I think would be more important when you go ahead with your career.
Thank you. Sridevi madam, tips for all the students from
I think Dr. Harish has said most of it. I think he's said. In addition, I think the basic things like, grading of tumor, scoring of VRPR and all should be by heart, yeah. Even in your sleep, you should be able to answer them. Okay, and you rightly, if you didn't know, you said you don't know. That's better than trying to answer a wrong question. And I find that many of you hesitate to give a differential diagnosis, not only for breast cancer, for abdominal lumps also. Often when you're asked for a differential, I think you should keep an open mind and give differentials pertaining to the findings that you have elicited. So I think it's a good practice to learn to have a differential diagnosis wherever it's appropriate. If it's not appropriate, you don't have to give. Otherwise, you did reasonably well, but I think Dr. Harish has summed it up very well. Narendra?
Thanks. Narendra? Narendra, unmute. Narendra, unmute. Okay, maybe he lost the internet, I think. Narendra?
It's time for 1 hour, I think.
Yeah. Thank you very much, ma'am.
No
I
problem.
could join only half, but it was very good discussion. And breast cancer and oral cancer is something where everything should be answered to pass. It is not a case where you can get distinction or higher brownie points. It is one case which there is no forgiving for a surgical onco student. So they need to know this.
Perfect.
So still,
This
thank
is
you
like
very much.
It is like an inguinal hernia and channel surgery. You have to answer all questions.
Correct. And everybody will get a oral cancer and breast cancer mandatory in surgical onco. So there is
Almost,
no.
yeah. Absolutely.
Yeah. Thank you. Thank you very much, Sridevi.
Thank you, Dr. Harish.
Thanks, Hari.
Thank you, Dr.
Thanks,
Om.
Narendra.
Thank you.
Wholehearted thanks from all the students, myself, and DNB board. In spite of very busy schedule, all three of you
No.
really spent a lot teaching.
Pleasure.
Thank you very much.
Pleasure. Yeah,
Thank you.
bye.
Thank you. So, Aaron, okay, you did well. Still, a lot to do. You understand just theory, knowledge doesn't help. Application of practical in exam, suddenly how you go blank. That is what exam is. Integrating actual practical and all the knowledge and putting into proper basics. Still work to do, but still you did well. No problem. Remain calm. Don't get tense. It's easy. When we were students, we had it. But that is what is exam, right? Trying to control that and still be on the right path. Thank you. And over to you, Navneet Singh ji.
Thank you. Thank you very much, trainees and faculty members, for joining.